Welcome to our lecture series. We are currently continuing our lecture series in hematology. Topic for today is plasma cell dyscrasia, and our speaker for today is Dr. Anup J Devasia. Sir finishes MD from St. John's batch of 2011, followed by DM in clinical hematology from CMC Vellore 2015 batch. Currently is working as associate professor in the Department of Hematology CMC Vellore. Sir's area of interest, plasma cell disorders and stem cell transplant. And over to you, sir. And if you have any doubts, please comment your questions in the chat box. We'll be able to answer towards the end of lecture.
Good afternoon, everybody. In today's medicine lecture series, in today's lecture, I will be talking on the diagnosis and management of plasma cell disorders. So on the left panel, you see the ontogeny of the B cells. And so this is the normal development of the B cell. So B cell starts as a lymphoid progenitor or the B cell lymphoblast. And through the various steps of differentiation and maturation, it finally becomes what is known as the mature plasma cell. A plasma cell is the mature form of a B cell. And at various stages, you can see on the right side that these are the diseases that are associated with the B cell, associated with the B cells in the various steps of its differentiation and maturation. The diseases that are associated with clonal proliferation of plasma cells are called plasma cell disorders, and the most common plasma cell disorders that we usually encounter in the clinics are the multiple myeloma spectrum, which includes the symptomatic or the asymptomatic phase of multiple myeloma called as MGUS and smoldering myeloma, and then the terminal phase of multiple myeloma called as plasma cell leukemia. The other spectrum of diseases which comes in the plasma cell disorders are plasmacytoma, primary systemic amyloidosis, Poems syndrome, and Waldenstrom's macroglobulinemia. The most common out of these that is usually seen is the spectrum of the multiple myeloma disorders and the plasmacytoma. So in simple terms, multiple myeloma is a disease characterized by the neoplastic proliferation of a single clone of plasma cells. Now, if you look at the immunoglobulin molecule, now you should understand that the mature plasma cell produces an immunoglobulin, and this immunoglobulin is a key piece of immune function. So looking at the structure of the immunoglobulin, you know there is a heavy chain and a light chain, which is joined at the hinge region. The main function of the immunoglobulin is the immune functions. Now, what happens normally is that in the normal individual, there's normally polyclonal immunoglobulins which are produced. You know, the immunoglobulins ranging from IgG, IgA, IgM, IgT, and IgE. And these polyclonal immunoglobulins provide a broad protection against the numerous antigens. In multiple myeloma, what happens is there is loss of the polyclonal nature of immunoglobulin, and there is a development of a single clone of an abnormal immunoglobulin because of the abnormal proliferation of a single clone of plasma cell. And this immunoglobulin is called as a monoclonal immunoglobulin, which causes what is called as the M spike in myeloma. This loss of the polyclonal immunoglobulin and its immune function and the proliferation of a monoclonal protein results in the various infectious complications in multiple myeloma. If you look at the epidemiology of multiple myeloma, this is data from the West. It comprises around 1% of all the cancers. 10 to 15% of hematological malignancies are multiple myeloma. We have data of incidence from the US. It's around 4 to 5 per 100,000. It is usually found in the 6th and 7th decade, but rarely patients can be seen in the younger age group. 10% of patients are less than 50, and very rarely 2% of them can be found when they are less than 40. And men are more affected than females. Now, looking at the spectrum of plasma cell myeloma, and which is called as monoclonal gammopathies, you have to understand that as the tumor burden slowly increases, multiple myeloma has got two asymptomatic phases. The first one is called MGUS, or the monoclonal gammopathy of undetermined significance. And as the tumor burden slowly increases, it becomes smoldering multiple myeloma. And when there is end organ damage, which is caused by the monoclonal protein and the plasma cell, you call it as multiple myeloma. So in MGUS, you know that the M protein is less than 3 grams per deciliter. The bone marrow plasma cells are less than 10%, and this is not sufficient enough to cause any end organ damage. This is found in around 3 to 4% of population in patients who are in people who are more than 50 years, and the incidence increases to 5% in people who are more than 70 years. This is a completely asymptomatic phase and does not require any treatment. As the M protein slowly increases to more than 3, and as the bone marrow and the bone marrow is still showing plasma cells less than 10%, and it still does not cause any end organ damage, and that phase is called a smoldering multiple myeloma. And once this M protein and the bone marrow plasma cell causes symptomatic myeloma or causes end organ damage, that is the phase called multiple myeloma. Now, if you look at the progression of the multiple myeloma from the precursor lesions, this is the graph showing the progression of smoldering myeloma and MGUS. The progression of MGUS is almost similar, is almost same throughout the course of a person. So the MGUS to multiple myeloma progression is around 1% per year. Whereas if you look at the progression of smoldering myeloma, in the first 5 years, 10% of people can become multiple myeloma. It slowly decreases to around 5% per year in the second 5 years, and after 10 years, the progression of MGUS and smoldering myeloma are almost equal. So if you look very closely at this graph, you can see that in the first 5 years, the graph of smoldering myeloma is very steep. It slowly slants down, and after 10 years, the graph of progression of MGUS and smoldering myeloma are almost parallel. So which means that if a smoldering myeloma has to progress to multiple myeloma, the maximum chance of progression is in the first 10 years, and after first 10 years, the chance is very, very negligible. Now, looking at the criteria for diagnosis of multiple myeloma, the 2009 criteria, which is given by the International Multiple Myeloma Working Group, you need to have plasma cells more than 10%. You had to have a monoclonal protein, and you also had to have the end organ damage, which is called as CRAB, where C stands for hypercalcemia, where serum calcium is more than 11.5, R for renal insufficiency, where the creat is more than 2, A for anemia, where hemoglobin is less than 10, and B for the bone lytic lesions or severe osteopenia or pathological fractures. Now, what happened after that is, now among smoldering myeloma, that means in patients who had an M protein and a plasma cell without end organ damage, there was a group of patients who were called as high-risk smoldering myeloma, and these were the group of patients who had high-risk smoldering myeloma. And when these patients were followed up for a long time, they found that 3 sets of patients, that is, if you have a bone marrow clonal plasma cell more than 60% even without end organ damage, or if you have a serum free light chain ratio of more than 100 at diagnosis, or if you have abnormalities in the MRA which shows more than 1 focal lesions in the marrow, in these subset of patients, the chance of these patients progressing to multiple myeloma was around 80 to 90% compared to the other group where the progression was less. And so in 2014, there was an updation in the criteria, and these patients with these 3 other criteria or the other 3 features were also put as diagnosed as multiple myeloma, and then the recommendation was also to treat these patients as multiple myeloma. So the 2014 updation for multiple myeloma includes the 3 new biomarkers for multiple myeloma. Also, it was found that 3 to 5% of multiple myeloma are non-secretory, and in such patients, MBAN or light chains are not produced. So in 2014, the criteria was slightly modified. This was the 2009 criteria. This was modified. The monoclonal protein criteria was taken off. You had to have bone marrow plasma cell more than 10%, and then you had to have what is called slim CRAB. 1 out of the 4 of slim CRAB criteria had to be present. In the next few slides, I will tell you what is slim CRAB. So this is the new updated 2014 criteria. You have to have both the criteria. So you had to have clonal bone marrow plasma cell more than 10%, or a biopsy proven bony or extramedullary plasmacytoma. That was the first criteria. The second criteria was that you had to have any of the below said myeloma defining events, which is now updated from CRAB to slim CRAB. I will go through it in the next few slides. So CRAB, which was found previously, was again calcium more than 11.5, creat more than 2, hemoglobin less than 10, and bone lesions. Now this was updated to slim CRAB, where they have brought in the three biomarkers, that is S is for the more than 60% plasma cells in bone marrow, even if all the other criteria are absent. Li is the light chain ratio more than 100, and MRI showing more than one focal lesions in the marrow. So these three, along with the conventional CRAB, now fits into the new myeloma defining events. And understand that this actually came from the follow-up of patients with high-risk smoldering myeloma, where they found that if you have any of the first three criteria, the chance of developing myeloma was 90% to 80% at 2 years, and these patients had to be treated like multiple myeloma. So right now, this is the new myeloma defining events. If you look at the pathogenesis of multiple myeloma, this graph sort of summarizes what happens in multiple myeloma. So you can have bone marrow infiltration, which can cause anemia and various degrees of cytopenia. As I said, there is the polyclonal nature of immunoglobulin is lost. So there is reduced normal immunoglobulin, which can increase the propensity for infections. There is abnormal monoclonal proteins, which can cause hyperviscosity, renal failure, and neuropathy. And there is also bone destruction, which causes lytic lesions, pathological fractures, and hypercalcemia. Now, what happens in the kidney in multiple myeloma? Now, this is the cause of renal failure in myeloma. So you have the kappa and the lambda light chains, and these are not absorbed in the proximal tubules, and these can cause direct toxic effect to the tubules. And again, you can have the formation of cast in the nephron, and which can cause cast nephropathy in the thick ascending loop of the distal tubule. This, along with the other features like hypercalcemia, dehydration, hyperuricemia, other nephrotoxic drugs like NSAID, or any contrast which is used for imaging, can cause renal failure in multiple myeloma. Looking at what happens in the bone in multiple myeloma, the usual bone balancing act is usually by the osteoclast and the osteoblast. What happens in multiple myeloma is there is osteoclastic activation and osteoblastic inhibition. So because of this osteoclastic activation and osteoblastic inhibition, the balance is tilted more towards bone destruction. So there is bone resorption, which causes lytic lesions, pathological fractures, compression and collapse of the vertebra, plasmacytomas, and hypercalcemia. Because there is osteoblastic inhibition in multiple myeloma, the alkaline phosphatase is usually normal in patients with multiple myeloma, but rarely you may come across a patient with a very normal or a high alkaline phosphatase, and the reason is that mostly it is because of bone formation after a fracture in multiple myeloma. Otherwise, in almost all cases of multiple myeloma, the alkaline phosphatase is usually normal. Now, looking at the clinical presentation of multiple myeloma, depending upon the pathogenesis and the manifestations, you can have pain, fracture, spinal cord compression related features, and radiculopathy if there is bone destruction. Hypercalcemia can cause polyuria, polydipsia, nausea, vomiting. In severe degrees of hypercalcemia, the patient can be obtunded, the alertness can be decreased, and in severe cases, the patient can have constipation. Renal failure usually presents non-specific symptoms like nausea, vomiting, malaise, and weakness. Bone marrow infiltration can cause various degrees of cytopenia, anemias, and bleeding tendencies. The reduced globulins, the reduced normal globulins or the immunoglobulins can cause recurrent infections and pneumonia by the capsulated organisms. Hyperviscosity can cause shortness of breath, features symptoms of transient ischemic attack, retinal hemorrhages, epistaxis, and deep vein thrombosis. Now, the clinical features, around 50 to 70% of patients can have CRAB features. Almost 1/4 of patients can have hypercalcemia. Creat can be abnormal in around 50%. Almost 3/4 of patients presents with anemia, and 50% of patients can have bone pains and fractures. In a very less proportion of patients, you can have paresthesias, hepatomegaly, splenomegaly, lymphadenopathy, and fever. This ranges from 1 to 5%. Non-specific symptoms like fatigue, weakness, and weight loss can be seen in around 1/4 of patients with multiple myeloma. Now, in the clinic, when do you suspect myeloma? When a patient comes to the clinic with bone pain and lytic lesions, there is an increased protein concentration or the presence of a monoclonal protein. If there is an alteration in the albumin globulin ratio, if there is unexplained anemia, hypercalcemia, pathological fractures, or a combination of anemia with renal failure, you have to strongly suspect multiple myeloma. Now, what makes multiple myeloma very unique is the fact that it's a great mimicker, and depending upon the clinical features, the patient can present to the various specialties. The patient develops anemia, the patient can go to a physician or a hematologist. The patient presents with features of renal failure like pedal edema, anasarca, or decreased urine output. They may contact a nephrologist. Altered sensorium and neuropathy, the patient can go to a neurologist. Other non-specific symptoms like nausea, vomiting, again, they can go to a physician or gastroenterologist. And if there is fractures or any trivial trauma causing any fractures, the patient can go to an orthopedician. And this is what makes multiple myeloma unique and sometimes very difficult to diagnose. Now, depending on the monoclonal protein that is produced, you can have a secretory myeloma where the plasma cell secretes the immunoglobulin heavy chain or a light chain, which is around 97% of patients, out of which with the majority produces the heavy chain IgG, which is around 50%. Next comes IgA, which is around 20%. 20% of secretory myelomas produces only the light chain kappa or lambda, and very rarely you can have heavy chain IgD, IgE, or a biclonal protein in around 7% of patients. But keep in mind that 3% of myelomas are completely non-secretory. Here the plasma cells may not secrete a monoclonal protein, which means that a myeloma can happen even in the absence of a monoclonal protein. Now, once you have a patient, you look at the investigations to evaluate the patient. So the investigation panel ranges from complete blood counts where you can find anemia, peripheral smear may show rouleau formation and normocytic normochromic anemia. The liver and kidney function test may show features of renal failure. There can be alteration in the albumin globulin ratio. Serum electrolytes and LDH needs to be done. There can be hypercalcemia. Uric acid can be high. You also need to quantify and qualify the monoclonal protein. So you have to do the serum and urine electrophoresis, urine Bernstein's proteins, serum free light chain assay, look at the immunofixation electrophoresis. Bone marrow studies has to be done. This is to demonstrate the clonal nature of the plasma cell, and also FISH has to be done to look at the various karyotypes and the cytogenic abnormality, which has got very much importance in the prognostication. Immunoglobulin levels have to be done. Skeletal survey can range from X-rays to CT to MRI to PET-CT. If an X-ray is done, make sure that the minimum panel includes X-ray of the skull, pelvis, spine, and long bones. Beta-2 microglobulin has got prognostic role, and then tissue biopsy has to be taken if you find any other plasmacytomas apart from the involvement of bone marrow. Now, these are the various manifestations in the lab. So you can have normocytic normochromic anemia and rouleau formation on the peripheral smear. The images on the right side shows the aspirate and the biopsy from the bone marrow. The aspirate shows a typical bone marrow showing the plasma cells, which shows the peripherally pushed plasma cell with the nucleus, which is peripherally pushed with the perinuclear half, and the trephine shows dense infiltration of the plasma cells. This is the serum protein electrophoresis, which shows a characteristic M spike at the gamma region, which is called as the monoclonal protein. And then the one below shows the immunofixation, where you have the ELISA test, which is showing IgG band and the kappa. So this is a IgG kappa multiple myeloma. So these are the usual investigations done for multiple myeloma. Skeletal survey can pick multiple lytic lesions in the skull. The severest form is called as the pepper pot skull. You can have pathological fractures in long bones. You can have, again, lytic lesions in the bones. You can have compression and collapse of the vertebra. Again, you can have pathological fractures, and rarely you can also find plasmacytomas, which can be bony or non-bony, which can involve various sites of the body. Now, prognostication in multiple myeloma, the standard prognostic system that is used now is the international staging system, where you have two lab parameters. You look at the serum beta-2 microglobulin and the albumin. If the serum beta-2 microglobulin is less than 3.5 and the albumin is more than 3.5, we call it as ISS1. If the serum beta 2 microglobulin is more than 5.5, irrespective of the serum albumin, you call it as ISS3. And what is not ISS1 and ISS3 is labeled as ISS2. Now, depending upon the staging, you can see that the median survival changes. The median survival is around 62 months in patients who are ISS1. It comes down to 44 months which in patients who are ISS2, and almost to 2 years in patients who are ISS3, where the serum beta 2 microglobulin is more than 5.5. With the advent of the newer prognostic marker, that is karyotype, the revised ISS has taken place. And so revised ISS, along with the parameters used for ISS, uses cytogenetics and LDH. So if you have features of ISS1 with no high-risk cytogenetics and a normal LDH, you call it as RISS1. If you have features of ISS3 and you have a high-risk cytogenetics, which is classically a translocation between chromosome 414, translocation between 1416, or a deletion in 17p, or an elevated LDH, you call it as RISS3. And again, what is not RISS1 and RISS3 is called as RISS2. And this PFS curve shows that when you move from RISS1 to RISS3, the prognosis can change and the survival can become less. Now, looking at the treatment of multiple myeloma, before going to the treatment, it is very important to understand the natural history of multiple myeloma. This is how a typical patient with multiple myeloma behaves. So in myeloma, there is usually an asymptomatic phase or the smoldering myeloma. Here, treatment is not required. As the monoclonal protein slowly increases, it causes what is called as end organ damage, and that is what is called as active multiple myeloma or multiple myeloma. And at this symptomatic phase, treatment or first-line therapy is given. And with the treatment, the patient usually go for response. They respond in various degrees. And then it is very important to know that all patients with multiple myeloma can eventually relapse at some point of time. At that point of time, you give the second-line therapy. Again, they go to a remission or a palliative phase, and then again, they relapse at some point of time. After multiple relapses, myeloma can become a relapsed refractory disease. So it's very important to understand that there is no cure available for multiple myeloma in most of the cases, and the treatment is mainly aimed at controlling the disease. So the main aim of therapy in myeloma is to extend the disease-free period with the modalities of treatment that are available. Looking at when to treat a patient with plasma cell disorder. So as I said, MGUS and smoldering myeloma are the precursor lesions. They are asymptomatic. The patient does not have symptoms and the patient does not have any end organ damage. So in MGUS, there is no need of any treatment. The patient needs only a 6-monthly follow-up. Whereas if it is a smoldering myeloma, you need a more close follow-up, especially in the first 10 years, because the chance of progression to multiple myeloma is maximum in the first 10 years. So here you need 3-monthly follow-up with the blood parameters. If a patient has got multiple myeloma, treatment has to be initiated as early as possible. This slide shows the various drugs that are available for treatment of myeloma. So you can have alkylators, which are melphalan and cyclophosphamide. You can have corticosteroids, anthracyclines, immunomodulators ranging from thalidomide, lenalidomide, and the newest one is pomalidomide. We can have proteasome inhibitors, bortezomib, carfilzomib, and exosomib. And now there is also the availability of monoclonal antibodies called daratumumab and adotuzumab, which are available for treatment of multiple myeloma. In multiple myeloma, essentially, a combination of these drugs are used. So either you use a doublet where you combine 2 classes of drug, or a triplet where you combine 3 classes of drug. Now, what has this treatment done to the survivor in multiple myeloma? So in the 1950s, the only available treatment was prednisolone. This happened for almost 10-15 years till melphalan was discovered in 1962. And then from 1960 to 2000, the only available agent was steroids and melphalan. The early 2000s and the late 1999, there was the discovery of the immunomodulators, thalidomide in 1999 and bortezomib in 2000. and then came lenalidomide, pomalidomide, carfilzomib, etc. And what these drugs has done to multiple myeloma is the survival of multiple myeloma has significantly improved. So if you look at the era of steroid, the 5-year survival was seen only in 10% of patients. But as the immunomodulators and the novel therapy has come, the survival has increased. And with the new immunomodulators and the new proteasome inhibitors, the survival of multiple myeloma, as the 5-year survival has almost improved to around 70%. So multiple myeloma patients are living long, and myeloma is now considered as a chronic disease, which can be controlled well with the medicines. Now, how do you approach a patient with a newly diagnosed myeloma? Essentially, you need to decide whether the patient is transplant eligible or not transplant eligible. This eligibility is defined by the age of the patient. Generally, up to 60 to 65 years is the age where we consider as transplant eligible. Look at the performance score and the comorbidities. If the patient is having a good performance score without comorbidity or well-controlled medical comorbidity, these patients are considered to be transplant eligible. If the patient is old age with poor performance status, and if the patient has got significant uncontrolled comorbidities, these patients are called as non-transplant eligible. And here, the patient needs to be given induction treatment for 9 to 12 months, followed by maintenance. If the patient is transplant eligible, you need to give induction treatment. It's very important to understand that you have to give a non-alkylator based induction treatment, which means you need to avoid melphalan, because melphalan can hamper the stem cell mobilization. This has to be given for 4 to 6 cycles. Once induction therapy is over, stem cell harvest has to be done and autologous stem cell transplantation can be done. Even after a transplant, the patient with multiple myeloma will need a long-term maintenance therapy. So these are the induction therapies which are available for transplant eligible patients. In the previous slide, I said we always use a combination of the various class. So you can have doublets where you combine 2 classes of drugs, or you can have triplets where you combine 3 classes of drugs. Now, comparing between a triplet and a doublet, generally a triplet induction regimen is preferred over a doublet regimen, because there are studies which have shown that if you give a triplet induction therapy, the responses are deeper, you achieve the response quickly, and these response can be sustained, and you can have an early attainment of the various degrees of response. On the right side, I have summarized the various triplet and the doublet regimens that are available. So you can combine a proteasome inhibitor, bortezomib, with an immunomodulator and steroid. You can combine bortezomib with alkylator and steroid. Now, cyclophosphamide is an alkylator which does not cause much impairment of stem cell mobilization. So cyclophosphamide can be used, but melphalan has to be avoided in patients with multiple myeloma who are transplant eligible, or in patients whom we are planning for autologous stem cell transplants. So again, these are the other combinations which can be tried as triplets or doublets. Now, the question is, in the era of novel agents, do we need a transplant? A long debate going on whether you have to do a transplant front or not do a transplant. There is cons and pros for both, for transplant and not for transplant. Generally, the toxicity is predictable, the responses are durable, and we can always hope that if you do a transplant, it may eliminate the cancer stem cells and the responses can be long-term. Because of predictable toxicity, the transplant-related mortality is only 1 to 2%. So in the current world, the standard of care for multiple myeloma is that if a patient is eligible for a stem cell transplantation, all these patients should undergo a transplant with the first response. Now, this is data from the Indian Society for Blood and Bone Marrow Transplant Registry. Now, this shows the indications for transplant. On the left side, you can see the indications for allotransplant. On the right side, the indications for autotransplants, and see that more than 50% of autotransplants done in India are for multiple myeloma, and then comes lymphoma and the other diseases. So multiple myeloma patients have to be transplanted, and this forms the major constituent of patients who undergo autologous stem cell transplant. In patients who are transplant ineligible, you can again use the same induction therapy that you are using for transplant eligible patients. In addition, you can also use lenalidomide, melphalan, etc., Melphalan can be used in this patient because you are not planning for a transplant, and so you don't have the worry of stem cell mobilizations. Again, these combinations can be either doublet or triplet, and again, triplet regimens are found to be better than doublet regimen. Along with treatment of multiple myeloma by chemotherapy, it's very important to understand that you need to manage the hypercalcemia, which is an emergency. So the patient has to be well hydrated. The patient has to be given diuretics. The other treatment for hypercalcemia are steroids, bisphosphonates, calcitonin, and dialysis. Be very careful when you use bisphosphonates because bisphosphonates are contraindicated in severe renal failure, and always examine the patient's dental status before you give bisphosphonates, because if you have a dental carie or any major dental procedure which is done within 2 months, bisphosphonate use can cause necrosis of the jaw. Renal failure is managed by hydration. You need to avoid all the nephrotoxic agents like NSAIDs, IV contrast, and other nephrotoxic antibiotics. If all the medical therapy fails, dialysis can be done. Bone disease, there is use of bisphosphonates, and I said bisphosphonates are contraindicated in severe renal failure, which is defined as creatinine clearance less than 30, and also examine the dental status of the patient, because in patients with dental caries, if you use bisphosphonates, the patients can have osteonecrosis of the jaw. Analgesia has to be given because majority of the patients presents with pain. Braces and spinal support has to be used. You can use radiation for pain relief, and then anemia has to be managed with blood transfusion. Now this slide sort of summarizes the mechanism of action of bone protection in myeloma. The conventional one which is used is the bisphosphonates. The most common one that is used is zoledronic acid. So what happens is the bisphosphonates coats the bone surface and prevents the osteoclast from eroding the bone. If bisphosphonates are contraindicated, the one agent that can be used is a monoclonal antibody against the RANK-L ligand, which is called as denosumab. RANK is the receptor of activated NF-kappa B, and the ligand of RANK is called RANK-L. If you look at the mechanism of action of denosumab, this is the osteoclast precursor, which matures into a osteoblast. The osteoblast has got the RANK receptor on it, which further becomes the multinucleated osteoclast. You have the osteoblast, which produces the RANK-L, or the receptor of the, or the ligand of the RANK. So when the RANK ligand joins with the RANK-L, the osteoclast gets activated, and this causes osteoclastic activation and bone resorption. What denosumab does is, denosumab is an antibody against the RANK ligand, which prevents the combination of RANK-L and RANK, and thus it prevents the activation of osteoclast and further decreases the chance of bone resorption by osteoclast. So these are the two agents used for bone protection, bisphosphonates and denosumab. Now after treatment, how do you look at the response to treatment? So patient, depending upon the response, you can have a partial response, a very good partial response, complete response, or a stringent response. If the monoclonal protein becomes zero, or the monoclonal protein is absent, and the bone marrow plasma cells are decreased to less than 5%, you can call them as complete response. If the monoclonal protein is decreased to 90% but not completely gone, you call them as very good partial response. If the monoclonal protein decreases only more than 50% and less than 90%, you call it as a partial response. If you have a patient who has a complete response and there is no clonal plasma cells, and if the light chain ratio becomes completely normal, that's the deepest response that is available, and that is called as a stringent complete response. So this is how the response is assessed after multiple myeloma therapy. Now, I told you, looking at the natural history of myeloma, eventually all these patients can relapse, and you can have a biochemical relapse or a clinical relapse. In biochemical relapse, the monoclonal protein which had decreased or which had become zero can slowly increase, but you won't have any myeloma defining event, or you won't have any CRAB features. So if a patient has got biochemical relapse, it is defined as a slow increase in the serum monoclonal protein, urine M protein, bone marrow plasma cell, or a light chain ratio. If this biochemical relapse is associated with a reappearance of either hypercalcemia, renal failure, anemia, or bone lesion, you call it as a clinical relapse. Or a patient is also called to have a clinical relapse if the patient develops any extramedullary disease, either as a plasma cell leukemia or a plasmacytoma. If you develop a biochemical relapse, treatment need not be started immediately. These patients needs to be followed up often, but once you develop a clinical relapse, patient has to be started on treatment immediately. What happens with multiple myeloma with multiple relapse is that as the patient relapses again and again, the duration of response decreases, the sensitivity to therapy decreases. So you have to use novel and new novel agents for further relapses. So the initial treatment which was given for frontline treatment may not work in a patient when he relapses, and then that treatment which was given at the first relapse may not work at the second and the subsequent relapses. Also, at this point of time, the patient would also develop complications to the treatment. So as a patient with multiple myeloma develops multiple relapses, the expected survival or the duration of response keeps on decreasing as per the diagram shown here. So as the patient with multiple myeloma relapses again and again, the median response keeps on decreasing, and finally myeloma becomes a refractory disease. These are the new agents that are available for treatment of multiple myeloma. You can have kinase inhibitors, cell cycle inhibitors, along with the conventional therapy that is used. You can have monoclonal antibodies, signaling pathway inhibitors, etc. So these are the new armamentarium of drugs that are available for treatment of myeloma when they relapse, along with the conventional therapy which is used. Now switching from multiple myeloma to plasmacytoma. Now plasmacytoma means there is a single area of bone destruction which can be due to a clonal plasma cells, and you have to have a normal bone marrow aspirate and trophine biopsy. The skeletal survey should be normal. The patient should not have any crab features, and the patient should not have any M-band or any abnormality in the MRI. So this plasmacytoma can be either a bony plasmacytoma or an extramedullary plasmacytoma. Bony plasmacytoma usually occurs in the vertebrae, long bones, and skull, whereas an extramedullary plasmacytoma can happen in any soft tissue. So you can have a bony plasmacytoma. Remember that the bone marrow has to be normal and the patient should not have any other myeloma defining event. This is called as a bony plasmacytoma. You can have a solitary plasmacytoma without any clonal plasma cells in bone marrow. Here the treatment is local radiation followed by follow-up for progression. If you have a solitary plasmacytoma with bone marrow showing less than 10% of plasma cells, now this is called as solitary plasmacytoma with low bone marrow involvement. Again, systemic therapy is not required. Local radiation for the solitary plasmacytoma and follow-up is what is required. Whereas if you have a solitary plasmacytoma and a bone marrow showing more than 10% clonal plasma cell, here the treatment has to be like multiple myeloma, and anti-multiple myeloma therapy has to be started immediately. Looking at plasma cell leukemia, I had told you that with each relapse, myeloma becomes refractory and finally reaches a refractory stage. And this most aggressive and the terminal relapse refractory phase of multiple myeloma is called as a plasma cell leukemia. Here what you can see is the plasma cell starts appearing in the peripheral blood. It's a very rare malignancy, but it is associated with a very aggressive clinical course. This is diagnosed based on the peripheral smear finding. So along with features of multiple myeloma, you should have more than 2000 circulating plasma cells per liter in the peripheral blood, or the peripheral blood plasmacytosis should be more than 20% on a differential count. If one of these parameters are positive, you can call them as a plasma cell leukemia. Plasma cell leukemia can either occur as a primary plasma cell leukemia or a secondary plasma cell leukemia. In primary plasma cell leukemia, the presentation is de novo without any previous history of multiple myeloma. Whereas a secondary plasma cell leukemia, a patient with multiple myeloma can have multiple relapse and finally is a terminal phase of multiple myeloma. Primary PCLs are usually found in younger patients. They have a very high plasma cell load. Extramedullary diseases are more common, and majority of these patients present with renal failure. Both of these are highly aggressive with very high tumor burden. If you look at the survival, you can see that these disorders are aggressive with very poor outcomes. The secondary plasma cells compared to primary plasma cell leukemias have got a inferior and dismal outcomes. The fact being that these are patients who had multiple myeloma, who have become refractory to therapy. And if you look at compare between primary and secondary plasma cell leukemia, dismal prognosis is seen in patients with secondary plasma cell leukemia. Treatment, there is lack of effective therapy which can achieve sustained responses in plasma cell leukemia. They're treated similar to patients, similar to the multiple myeloma patients. Young patients, allogeneic stem cell transplantation is an option. In patients with secondary plasma cell leukemia, because of the lack of a standard therapy and because of the extremely dismal outcomes, palliation is a treatment option. And either of these, whether it be primary or secondary plasma cell leukemia, remember that the prognosis is poor and outcomes are dismal. Looking at amyloidosis, now these are a rare group of disorders which are characterized by protein folding abnormalities, where more than one organ is infiltrated by the abnormal protein deposits, and these abnormal protein deposits are called amyloid. And these amyloid proteinaceous material causes fibrillar material, and these are formed from the precursor proteins that self-assemble with the beta cross beta pleated sheet conformation. So this is the microscopy of the amyloid. So you can see the pale eosinophilic appearance of amyloid. Now when this is seen under the polarizing microscopy, this is a typical apple green birefringence that is seen. And again, you can have the immunohistochemistry and the electron microscopy, electrofluorescent microscopy, which will highlight the amyloid. Now, depending upon the initiating factors, you can have different types of amyloid. The most common amyloid is what is called as the AL amyloid or the amyloid light chain associated amyloid. Here, the underlying trigger is a plasma cell disorder and the precursor protein is the monoclonal immunoglobulin light chain. This is found in around 60 to 70%. So majority of the amyloid is AL type. The other rare amyloids are AA or the amyloid associated protein, ATTR or the transthyretin gene associated, the amyloid fibrinogen alpha, amyloid associated with the LEC2 protein, apolipoprotein associated amyloid, lysozyme associated amyloid, galsosine associated amyloid, and the A beta 2 microglobulin associated amyloid. The most common one, as I said, is the AL amyloid, where the underlying disorder and the trigger is a clonal plasma cell disorder, where the monoclonal protein initiates the formation of amyloid and this deposits in the tissues. So the treatment of amyloid, if the patient can be typed as an AL amyloid, the treatment has to be like a patient where you treat multiple myeloma. Whereas in all the other types of amyloid, the initiating or the underlying disorder has to be controlled along with the supportive care for the organs. Now, when do you suspect amyloid? Now, these are the red flag signs where you should suspect amyloid. The patient who is a non-diabetic presents with nephrotic syndrome. A patient without any history of ischemic heart disease comes with a hypertrophy on the echo. A patient without any abnormalities of the liver on imaging presents with hepatomegaly or a raised alkaline phosphatase. A patient can present with CIDP with a monoclonal protein, or a patient with a monoclonal gammopathy in the presence of unexplained fatigue, edema, weight loss, or paresthesia. These are the set of patients where you should start suspect amyloid and look at the workup. I said AL amyloid is the most common type of amyloid. Around 70% of amyloids are AL amyloid. Here the initiating event is the clonal proliferation of plasma cells, and here the treatment is similar to the treatment of multiple myeloma. Looking at POEMS syndrome. So historically, POEMS syndrome is known by the acronym POEMS, where P stands for polyradicular neuropathy, O for organomegaly, E for endocrinopathy, M for monoclonal plasma cell disorder, and S for skin changes. But in practice, you may not find a patient with all these classical features. The updated criteria for POEMS syndrome is given in the next table in the slide. So you have to have mandatory criteria, major criteria, and minor criteria. The mandatory criteria are two. One is a polyneuropathy, which is a demyelinating neuropathy. And then you also should demonstrate the presence of a monoclonal plasma cell protein. And almost all cases, this monoclonal protein is a lambda type. So both the mandatory major criteria has to be present. Along with it, you should have one major criteria, and the major criteria is Castleman disease on biopsy, sclerotic bone lesions, and increased levels of vascular endothelial growth factor or VEGF levels. The minor criteria are organomegaly, extravascular volume overload, endocrinopathy, skin changes, papilledema, thrombocytosis, and polycythemia. So to diagnose POEM syndrome, you should have both the mandatory criteria plus one major criteria plus one minor criteria. This is how POEM syndrome is diagnosed. Now, depending upon the degree of involvement, this is a suggested algorithm for treatment of POEM syndrome. So you look at the iliac crest biopsy and the imaging. If there is no clonal plasma cells, you look at the bone lesions. If there are no clonal plasma cells and the bone lesions is less than 2, the treatment involves only radiation to the affected site. Whereas if the bone lesions are more than 2, systemic therapy with anti-myeloma agents have to be started. Now, if the patient's bone marrow shows clonal plasma cells along with features of POEM, irrespective of the number of bone lesions, these patients have to be started on systemic therapy. And on the right side, you can see the various treatment options that are available for patients with POEM syndrome. The last and rare plasma cell disorder that is seen is the Waldenstrom's macroglobulinemia. Now, this essentially is a low-grade lymphoma called as a lymphoplasmacytic lymphoma with the monoclonal protein being IgM. Patients with Waldenstrom's macroglobulinemia can present with anemia, thrombocytopenia, hepatosplenomegaly, lymphadenopathy, and hyperviscosity. The reason for hyperviscosity is the fact that IgM is a pentameric structure. It's the largest immunoglobulin molecule that's available. So when you have raised IgM levels, if hyperviscosity is there, and you can have symptoms of hyperviscosity. The most common presentation is fatigue secondary to anemia. But remember that it's a low-grade lymphoma, so these patients have to be treated only if they are symptomatic. The treatment agents include the same options that are used for treatment of multiple myeloma. So after discussing the various plasma cell disorders, let us discuss this case. This is a 62-year-old female who is diabetic and hypertensive for a long time, and this lady has come for evaluation of anemia. So this is the initial evaluation, which shows a hemoglobin of 9.7, MCV of 83.6, retics of 1%, WBC and differentials are normal, and platelets are 1,85,000. So this is the diabetic patient who has come for evaluation of anemia. Biochemistry was asked. This patient has got a creatinine of 4.1, calcium of 9, and protein of 6. So this patient has got anemia and renal failure. So at this point, we need to look at all the other myeloma workup. So M-band is 1.3. Skeletal survey shows generalized osteoporosis. There are no lytic lesions. Bone marrow shows 6% plasma cells. Urine BJP is negative. Serum free light chain ratio was showing a high kappa and high lambda, but the ratio was 3.22. The ratio was normal, and the immunofixation showed a IgA kappa. If you try to put this patient in the spectrum of the plasma cell disorder, you can see that this patient does not have bone marrow plasma cell more than 10%, which is the mandatory criteria for diagnosis of myeloma. But this patient has got a low level of M protein. This patient has got anemia, and this patient has got renal failure. So what do you think is the differential diagnosis here? Now this patient has got anemia and renal failure. So in such situation, always find out if anemia and renal failure are secondary to other causes. This patient underwent workup for anemia, and it was proved that this patient had anemia of chronic disorder. Kidney biopsy was done, and the reason for the renal failure was that this patient had diabetic and hypertensive nephropathy. So this patient essentially had anemia of CKD and CKD with a small monoclonal protein, and the final diagnosis was that hypertension, diabetes with anemia or CKD with a monoclonal gammopathy of undetermined significance. I brought up this case just to find out that presence of MBAN is not always myeloma. So you need to, myeloma is one malignancy which is very exclusive that you need to fulfill the criteria. So the pathologist may call and tell you that there is plasma cells in the bone marrow, but you should look for the myeloma defining events and try to classify them on the precursor in the spectrum of myeloma disorders, because M-band can also be seen in MGUS, smoldering myeloma. It can be seen in other low-grade B-cell lymphomas, and a polyclonal band can be seen in chronic inflammation. Now, conversely, myeloma can be diagnosed even if the M-band is negative. The reason is 3% of myelomas are non-secretory, and in this set of patients, M-band is not found in serum or urine. 30% of them will have a normal light chain ratio, and here bone marrow biopsy has to be done, and here we have to show that there is a clonal nature of plasma cells on the histopathology. Thank you very much, and I will be happy to take questions.
Thank you, sir. We have one question in the chat box. Why is that autologous transplant works for myeloma, where the marrow is diseased, but leukemia requires an allogeneic transplant?
Okay. So if you look at the data of transplants in myeloma, allogeneic transplants has got a very high transplant-related morbidity because of the myeloma-related features, and majority of the myelomas essentially happens to patients more than 50 to 60 years. So in such patients, autologous transplants can be done. Now, autologous transplantation again is not going to cure myeloma. You know that the patient will still have clones of myeloma proteins in the bone marrow, but with the chemotherapy that you are given before the transplant, you are going to decrease the tumor load to such a negligible load, and again you are going to give chemotherapy and give the cells. In previous time, there used to be something called as tumor purge, where they used to filter out the tumor cells and give the rest of the bone marrow, but that also has not shown to be of any significant difference. Because autologous transplantation has got predictable toxicity, a very low TRM, and the risk of allotransplants like GVHD, rejection, etc. are not there, autologous transplantation still remains the standard of care for myeloma. But as you rightly said, autologous transplantation, even with a transplant, the chance of relapse is there in multiple myeloma.
The difference between the Waldenstone macroglobulinemia and IgM multiple myeloma and change of treatment.
Okay, so you can have an IgM multiple myeloma, but it is extremely rare to find an IgM multiple myeloma. To have a Waldenstrom's macroglobulinemia, the first criteria is that you have to prove that there is a low-grade lymphoma. So you have to have the typical features of the patient will come with fatigue. The patient may have lymphadenopathy, and biopsy from the node or bone marrow will show features of lymphoplasmacytic lymphoma. So you will have cells which have got both the morphology of lymphoid cells and plasmacytoid cells. So you have to have lymphoplasmacytic leukemia, lymphoma, which is a low-grade lymphoma. In addition to that, you should also have a high levels of IgM. So Waldenstrom's macroglobulinemia is diagnosed only if you have an LPL or a lymphoplasmacytic lymphoma with a high IgM level. In an IgM myeloma, you won't have any features of a low-grade myeloma. The typical features of myeloma will be present, but here the monoclonal protein will be IgM. That is how you differentiate between IgM and LPL and a Waldenstrom's macroglobulinemia. If it's an IgM myeloma, the treatment has to be like how you treat any other multiple myeloma. Waldenstrom's macroglobulinemia is treated only if the patient has symptoms or if the patient has got any clinical triggers for treatment, cytopenia, anemia, thrombocytopenia, hyperviscosity related symptoms. But the agents which are used for treatment for Waldenstrom's macroglobulinemia is again as the ones which are used for treatment of multiple myeloma.
In the oligosecretory and the non-secretory myeloma, is there any other specific criteria or only the bone marrow?
So in such situations, because there is no monoclonal protein that is formed, the chance of renal failure and anemia and the lytic lesions are very less because the proteins, the monoclonal proteins are not there to cause the end organ damage. So that is why the criteria very clearly says that if you have a bone marrow plasma cell more than 60%, even if there is no trap features or if there is no abnormal ratio of more than 100, just the presence of more than 60% of plasma cells is enough for you to diagnose multiple myeloma. So there you need to do a bone marrow and establish that you have clonal plasma cell. And in these patients, in majority of patients, the end organ damage won't be present and the bone marrow will show dense infiltration of plasma cell, which will amount to more than 60%. That's the only way we can diagnose patients who are non-secretory.
If you have any more doubts, I can put your doubts in the chat box. If there are no more doubts, we'll wind up the session. Thank you so much, sir, for giving your valuable time and giving an elaborate approach on plasma cell dysplasia. On behalf of Department of Medicine, we extend our thanks to Department of Haematology. And our next topic will be on ITP and TTP by Dr. Sharon next on the coming
Tuesday.
the next session. And this lecture will be uploaded in a week's time in our YouTube channel. Thank you.
Thank you very much.